Hello, this is Dr. Weaver, and today we're going to review emergency and critical care in preparation for taking the VTNE. Our test tip of the week is to rest on the day of the exam. So if you don't know it by the morning you're going to go take your VTNE, you're not going to learn it. Don't study the day of the test. Instead, concentrate on being calm and being confident, and really practice the positive self-talk. I can do this. I've studied hard. I know my stuff. If you spend 20 minutes saying, I'm going to fail, I'm going to fail, I'm going to fail, guess what? You're going to fail. You need to have positive self-talk, work on just being calm, taking care of yourself so that you will test well when you take your exam. Our lesson plan for today includes preparedness, triage, the primary survey when we have an emergency. We're going to review cardiac anatomy. We're going to go through CPR, which is cardiopulmonary resuscitation. We're going to talk about shock, respiratory emergencies, feline urethral obstructions, gastric dilation and volvulus, eclampsia, seizures, heat stroke, emergency nursing procedures, and toxicology. And just a reminder, this is intended to be a review of the emergency and critical care information. And so what that means is that you should have had this in a previous class, or if it's been a long time, you should be returning to your textbook and taking notes on the chapters that cover this information. This isn't all inclusive. This is just a review of the highlights. All right, so preparedness. It's always important to be prepared for an emergency, and this goes beyond just in the veterinary hospital. Something that we should all be thinking about in our homes and our home and work lives. We should be prepared. So in the emergency clinic or in the veterinary clinic, a crush cart should be portable, should be well organized, and always stocked. Things that we want to have in there include oxygen related supplies, so maybe an ambu bag and some endotracheal tubes, IV catheter and fluid supplies, so all the setup to place a catheter, tape it in, and run a bag of fluids, clippers, a tourniquet, bandage supplies. The emergency drugs should be in the crash cart, and a dosing chart is really helpful as well. I like the one that is from the Recover Initiative. So I have a little laminated emergency drug dosing chart in my crash cart. And then it's important to have syringes and needles. And, the supplies need to be regularly checked and then restocked when they're used. And so if anything's expired, it needs to be rotated out. And, just always having that crash cart ready in case of an emergency is important. If you're working in an emergency clinic or seeing urgent care patients, appointments are dealt with differently than a regular scheduled appointment. So if we're in a general practice, we have appointments scheduled regularly, and they could be a mix of wellness or, sick patients. And this is different. So when we're in an emergency hospital, we see the patients in order of need. And so triage means to sort. And this is the way that we assess our patients to decide who needs care first. It's about prioritizing care based on the patient's medical needs. And so if someone shows up with like an ear infection, they might end up waiting for a really long time, even though they got there earlier in the day, because the patient is stable and able to wait longer. So the order of appointments is based on the patient's need and not so much on who got there first or who scheduled first. And so triage is the system to sort our patients. And you'll find there's a lot of different systems to evaluate patients, but in general, we prioritize anything with the airway and breathing first. Airway means if the patient has an airway obstruction, like a ball stuck in the back of their throat, or anything that's causing them to be cyanotic, that is the first thing that we need to address. That's the patient that we need to take care of first, because they don't have long before they'll die from a lack of oxygen. Breathing would include things like pneumonia or respiratory distress from asthma or congestive heart failure. And so breathing is right after making sure the airway is open and clear. And then comes circulation. So this is related to the heart and after that would be other things. So it's this system here that I have up is the ABCD. And so disability includes a lot of different things, but including neurologic problems. And it's generally, there's a bit of nuance in triaging patients and different scales for levels of urgency. So you could have vomiting and diarrhea that is life-threatening if the animal's in anaphylactic shock. Or it could be a dog that's kind of just running around the exam room or the lobby barking, and it's less urgent. And so even as we evaluate the problems, we have to also think of the scale of urgency of that problem. So life-threatening is a patient that's in cardiac arrest or respiratory distress. Something that's emergent might be like a pretty bad laceration or a fracture. And then something that's urgent would be the vomiting or diarrhea. As long as that patient is still, kind of active and moving about, it's not going to be life-threatening. They can wait a little while. The first thing we want to look at when we are triaging a patient is their breathing. What is their respiratory rate? What is the pattern, or what is their respiratory effort? And so there's some respiratory emergencies that would warrant a immediate treatment. Let's go through some of these respiratory emergencies. Stridor is the sound we hear when the airway is narrowed in the laryngeal area. And an example is when a dog has laryngeal paralysis. We can hear this sort of like a roar when they're breathing. Stertor is what we hear when a brachycephalic is having a hard time getting air in and out, and it's a lot more from the nose. So stertor is like that sound. I'm sure you've all heard it if you've ever encountered a French bulldog. Cheyne-Stokes is a irregular breathing pattern that's characterized by periods of really fast, shallow breathing, followed by periods of apnea, and then the gradual increase in breathing rate and depth. This pattern is often associated with serious medical conditions like heart failure or stroke. Agonal breaths are an involuntary breathing pattern characterized by a spasmodic inhalation. It kind of looks as though they're gasping, and it's a sign that the brain is not receiving enough oxygen and the body is making a last-ditch effort to compensate. The patient is not conscious when agonal breaths occur, and we frequently see an agonal breath or two when we euthanize patients. Paradoxical respiration is when the chest falls and the abdomen rises during inhalation. So this is opposite pattern of what would normally occur. We see paradoxical breathing with respiratory distress and commonly with pleural space disease, but there are other causes as well. The video here shows a flailed chest, and this occurs when multiple rib fractures are broken and it creates an unstable segment of the chest wall that moves paradoxically during breathing. So that affected area moves inward when the dog inhales and then outward when they exhale, rather than expanding with the rest of the chest. So all of these respiratory emergencies would warrant a quick take the patient to the back and have them seen by the veterinarian and start treatment. After we evaluate the respiratory system, our triage survey next focuses on the cardiovascular system. So check the mucous membranes and check the pulses. If we find muddy mucous membranes that are kind of a little bit gray, it's not a nice bright pink. Muddy mucous membranes and weak pulses indicate poor perfusion. Brick red or hyperemic mucous membranes occur with septic shock. If we see brown mucous membranes, that could indicate methemoglobinemia and is often associated with acetaminophen toxicity. If the pulses are really snappy and the mucous membranes are pale, that might indicate anemia and hypovolemic shock. And then if we feel really bounding pulses, that could occur when the patient is in septic shock and a hyperdynamic state. Moving on with our primary survey, we're going to check for central nervous system emergencies. So we want to observe the patient's level of consciousness. And then if possible, we want to watch them walk around. This could either be in the exam room, or sometimes we might ask the owner to walk them up and down the hall to appreciate any abnormalities in the gait. We're going to look for other emergencies such as muscle twitching, head trauma, nystagmus, or a head tilt. Then we're going to move on to looking for life-threatening wounds. Does this patient have severe bleeding? Are there any punctures? Are there any contusions or open fractures? Remember, an open fracture is when the bone is coming through the skin. And just a reminder that dog bite wounds are often much more severe than they appear because there's trauma between the skin and the muscle layer. When the animal is bit, often the skin lifts up and is shaken a little bit. And so there's a lot of detachment between the skin and the muscular layer below. And those wounds are usually much more invasive than they appear. All right, let's practice. So an example of a problem you might see on the VTNE is a list of several patients that you need to triage. My strategy when I look at this is always to assess which patient is the most critical and which patient is the most stable, and then look for an answer choice that has those as the first and last patient that I would triage. Sometimes the in-between choices can be pretty close and hard to tell, but that's a strategy for a multiple choice exam on triaging patients. So here we go. A, we have a 3-month-old male Great Dane, presents for hives and a swollen face. B, we have an 8-year-old female spayed English bulldog presenting for coughing and difficulty breathing. On triage, she is cyanotic, stertorous, and very stressed. And then C, we have a 2-year-old female spayed beagle, presents with a hot spot at her tail base. She is extremely itchy and uncomfortable. So what do you think? Which of these patients is the most critical? B, I agree. So this patient is cyanotic, stertorous, and very stressed. That dog is not getting enough air and enough oxygen into its body. So that would be the one we want to see first. The second one we'll see is A. So the Great Dane with hives and a swollen face. Allergic reactions should be dealt with pretty soon. And then the one that can wait is the itchy beagle with the hot spot. And so that would be our most stable patient. That patient's not going to die even though they're uncomfortable. It is not a life-threatening condition. Let's review our cardiac anatomy. You should be able to name all the parts of the heart and also really understand the blood flow. And then before we go through each individual part, I want you to orient yourselves. So what direction does the apex of the heart point? Yeah, it points to the left. So in this picture, it's as though I was looking at a patient and they're looking back at me. So the apex is to the left, the patient's left. And then I also want to point out that the left side of the heart has thicker walls inside of it. And so they have to be thicker because they're pumping blood to the whole body. And so you can also recognize the thin right side of the heart with the thin walls and the strong left side of the heart with its thick walls. Number one on this picture is the aorta. The aorta is the biggest artery in the body and it makes a big arch over the heart. So you can recognize it on x-rays. You see this big arch over the top of the heart base, and that's the aorta. Number two is the cranial vena cava. And just remember, our patients are animals and walk horizontal. And so we use the terms cranial and caudal to describe the vena cava. And this is different than the terms they use for people. So people, it is superior and inferior for those same structures, but they stand upright. So they're named slightly different. The directional terminology is a little bit different for humans. Number three is the right pulmonary artery. This is taking blood to the lungs. Once it's oxygenated, it comes back through the pulmonary vein, which is number 4. Pulmonary vein takes blood over to the left side of the heart. But we're continuing around. We're still on the right. 5 is the right atrium. Blood squeezes from there through the tricuspid valve, which is number 6. This is a one-way valve that opens to allow blood to go from the atrium to the ventricle. The right ventricle is number 7. This chamber collects the blood and then gives a big squeeze, and that sends blood through the pulmonic valve, which is not labeled in this picture, and then into those pulmonary arteries. Number 8 is the caudal vena cava. So this is bringing the blood back from the back half of the body to the heart. So it's coming from the back half, whereas the cranial vena cava is bringing blood from the head, neck, and shoulders and arms to the heart. All right, coming around to the other side. Number 9 is the left pulmonary artery. So that's equivalent to number 3. 9 and 3 are the pulmonary arteries, but 3 goes to the patient's right side and 9 goes to the patient's left side. The blood gets oxygenated and it returns through the pulmonary veins. The left pulmonary veins are number 10. That blood is going to go into the left atrium, which is number 11, and then gets squeezed through the mitral valve, which is number 12. We need to remember mitral is on the left, tricuspid is on the right. The left ventricle is number 14, and then when that blood squeezes into the aorta, it goes through the aortic valve, which is number 13. So hopefully you can picture the flow of blood. It's kind of like a figure 8. We have one circulatory system sending blood to the lungs to pick up oxygen, drop off CO2. And then we have another circulatory system to the body where we drop off the oxygen and pick up the CO2. And so blood is constantly circulating between the lungs and the body in order to facilitate gas exchange. This is just another picture of the cardiac anatomy, and maybe this helps you to visualize the different structures. There's little arrows to show you the flow. I like this cross-section of the valves because you get an idea of scale. And so the tricuspid and mitral are pretty big valves, and the tricuspid has 3 cusps to it, whereas the mitral only has 2 cusps. So it could be the bicuspid, but that's not what it's commonly referred to. The aortic and the pulmonary valve, those are considered the semilunar valves. They're much smaller compared to the other ones. Now we need to review the conduction pathway. So remember, the P wave is the depolarization of the atrium. The QRS is the depolarization of the ventricles. And then the T is the repolarization. It kind of like all shakes itself out and goes back to normal. We can't see the repolarization of the atrium because it's happening at the same time as the QRS, but that QRS is so much, more powerful or stronger that it kind of hides the repolarization of the atrium. And so remember that the SA node is considered the pacemaker, and this is where the electrical activity starts. And the SA node is in the right atrium. There is just one SA node. This is where it all begins. And so the SA node contracts to its own rhythm. It beats to its own drum. It's a little nodule of cells that can just fire off regularly. The signal crosses the atrium into the AV node, which is the atrioventricular node. From there, it travels down the center of the heart in the bundle of His, and then it starts to separate and go to the left and the right. So it goes to the left in the left bundle branch, and it goes to the right in the right bundle branch. And then that causes the heart to squeeze. And I think of like one time when I was a kid, I stuck my finger in, I was hanging up the Christmas lights and I got shocked and my muscles contracted without me even trying to. So that little electrical current caused my muscles to contract. And that's the same way this current in the heart causes the muscles of the heart to contract. It's like when it goes from the SA node to the AV node, the atrium contracts. We get a little zap and then a squeeze. And then as it wraps around the ventricles, we get a zap and a squeeze. And so that's how the electrical signal relates to the heart contracting. I love this picture because it shows the action. We have the signal starting at the SA node in the right atrium. It goes to the AV node, down the bundle of His and the bundle branches, and then you see the heart contracting in response with that. And at the same time, we can see the ECG strip at the corresponding segment or at the same time, so you can kind of see it all happening together. So it's really important you understand how the heart works and you're able to name all of the different parts of the heart. Okay, next we're going to review cardiopulmonary resuscitation, also known as CPR. Most of the information that we use is based off the Recover Initiative, and this is a big study that looked at the research about CPR, what works best, what leads to the best outcomes, and so it's all evidence-based. There's research to support these recommendations. We divide cardiopulmonary resuscitation into 2 phases. The first part is just basic life support, which is the compressions and ventilation. I'll go over those in more detail. And then the other part of it is advanced life support, and that's IV catheter, monitoring, medications, recording, that kind of stuff. So let's talk about chest compressions. We want to start with chest compressions as soon as we can. It's something that we can do without any other equipment nearby. So maybe while we're running to grab the crash cart, one person can start the chest compressions. For dogs and cats, big and small, our rate should be somewhere between 100 and 120 compressions per minute. And our compressions should squeeze the thorax 1/3 to 1/2 the width of the chest. So if we're just lightly tapping on the surface of the heart, we're not going to generate blood flow and get the circulation moving. Now, different chest shapes have different recommended positioning. The picture here is a keel-shaped dog, and so for a keel-shaped dog, we're doing our compressions right over the heart, which is where the elbow meets the thorax, about 1/3 of the way up the side of the thorax. Now, if we have giant breeds, we're going to work on them in lateral recumbency, but our hands are going to be over the widest part of the chest or the tallest part, because there's no way we could actually compress the heart. They're so big. And so by compressing at the highest part, we get the most movement, which still creates blood flow through more of a suction or a negative pressure mechanism. For the barrel-chested dog, these are like our Frenchies or our English bulldogs. They're wider around than they are tall. We're going to put them in dorsal recumbency like a human, and we'll put our hands right over their heart when we do compressions. So it does matter what position we put them in based on their chest conformation. Now, cats and small dogs we usually do CPR in right lateral recumbency, and mostly you're using one hand. That's the thing to remember. We can either use circumferential compressions where our hands go all the way around the cat's body, or we can just squeeze between our thumb and our other 4 fingers, or we could use one palm, but we don't want to crush them by putting the weight of 2 arms and our whole body on a cat or a small dog. It would be too strong, too heavy. All right, as soon as we can, we want to intubate. Intubation is really ideal when an animal's in CPR, and it's recommended that we learn how to intubate in lateral recumbency so that the compressions can be concurrent with intubation. Once we have the endotracheal tube in, we want to inflate the cuff and start ventilating for our patient. Ideally, we're using an ambu bag hooked up to oxygen. And the rate of breaths should be 10 breaths per minute, which is 1 breath every 6 seconds. If you are on your own and you don't have anyone else doing CPR with you, the compression to ventilation ratio would be 30 compressions to 2 breaths. I think in most vet clinics, it's rare that you're going to be on your own, but say you were all by yourself, you would give 30 chest compressions and then 2 ventilations at a ratio of 30 to 2. All right, after we have achieved or started our basic life support, then we move on to advanced life support. We want to go ahead and place an IV catheter. We used to bolus everyone huge doses of fluids, but more recent research shows that they only need fluids if they're hypovolemic. So if they're in hypovolemic shock, open up the fluids, let them run. But if they have some other problem and they're normovolemic, like they've been drinking just fine, we don't need to bolus them a ton of fluids. We want to get our monitoring equipment on, and the 2 most helpful pieces of equipment are the ECG to look for arrhythmias, and the capnograph. Capnograph is really cool. We can use it to determine if our chest compressions are good enough. And so if we're doing really good chest compressions, our capnograph should get over 15. And when the patient has a return of spontaneous circulation, the capnograph will rise. So it'll all of a sudden pop up to 55, 60, and that tells us that they have a return of spontaneous circulation or they have a heartbeat again. So the capnograph is really beneficial during CPR. If we've given anything that can be reversed, we want to reverse it. So this would be reversing our alpha-2 agonist with something like antecedent or yohimbine, yohimbine. This would be reversing our opioids with naloxone. If we think we have a lot of benzodiazepines on board, we can reverse with flumazenil. So we want to reverse anything that can be reversed. Then we're also giving emergency drugs. So we usually will give atropine at least once, and then maybe give epinephrine every 4 minutes. And there's other drugs that could be given as well to help get the heart beating, to get our patient breathing, and to bring them back from their arrest. So how do we know they're back? This is where we see the end tidal CO2 pop up and we can palpate pulses. Compressions are done in 2-minute cycles. It is important to continue for those full 2 minutes, but after a 2-minute cycle, then we pause and check for pulses. Now, in an emergency, we can give drugs via the trachea at twice the dose that we would give intravenous. And the ones that can be given through the trachea are listed here. So you can remember naval, naloxone, atropine, vasopressin, epinephrine, and lidocaine. Those 5 drugs are totally fine to give intratracheally at twice the IV dose. So if I normally would give, 1 mg per kg IV, I'm going to give 2 mg per kg intratracheally. And this picture shows how we do it. So the patient is hopefully intubated, and we want to deposit the drugs as close to the carina as possible. The carina is where the trachea splits into the 2 main stem bronchi. And so we want to get the drugs pretty far down in there. And so you would use a red rubber catheter, pass it through the endotracheal tube, squirt the drugs in, and quickly pull it back out, and then continue ventilating for the patient. If we just squirt it in the back of their throat, that's not really going to do much. It's not going to be as effective. So it really needs to get down in the trachea, ideally as close to the carina as possible. Okay, next we're going to talk about shock. Shock is a complex syndrome that results from altered blood flow or impaired oxygen delivery to tissues. And if we don't do something about shock, it leads to death and serious complications pretty fast. So when a patient's in shock, we need to move quickly to try and get them out of shock by treating them aggressively. So at first, when patients are in shock, they might be depressed. They might also be anxious. Most often, they're tachycardic and tachypnic. The vitals can vary based on what type of shock they're experiencing, but for the most part, the heart rate is elevated for different types of shock. So tachycardia, tachypnea are common when a patient's in shock. Now, the pulses can vary. They could be normal, they could feel weak, or they could be increased and bounding. And we'll kind of talk through the different types of shock. So we'll review hypovolemic shock, distributive shock, obstructive shock, and cardiogenic shock. Hypovolemic shock occurs from the loss of intravascular fluids. We're talking about losing fluids from the vascular space. Causes include hemorrhage or really profuse vomiting and diarrhea, trauma, severe dehydration, third spacing of fluids, and this is worse than just dehydration. This is a more severe form of it. Clinical signs include tachycardia, prolonged capillary refill time, weak pulses, and hypotension. And the treatments are aimed at restoring the blood volume as quickly as possible. So we're going to need to place an IV catheter, administer IV fluids, maybe some synthetic colloids, maybe a blood transfusion for hemorrhaging patients. It is important to identify the source of the hypovolemia so that we can treat the patient optimally. Distributive shock occurs from maldistribution of blood and inappropriate vasodilation. Fluid therapy is essential in the treatment of distributive shock. So treatment will include vasopressors to restore normal vascular tone, and we might see weak or bounding pulses. Pink mucous membranes are generally seen. Let's talk about some examples. Anaphylactic shock is caused by a hypersensitivity to an allergen that leads to massive vasodilation, mast cell degranulation, histamine release, and other vasoactive mediators. Remember, in the dog, the primary shock organ is the liver and guts. So clinically, when these dogs have anaphylaxis, they will collapse with an acute onset of vomiting and diarrhea, sometimes hemorrhagic. In cats, the primary shock organ is the lungs. So cats will have profound bronchoconstriction and all respiratory signs when they're in shock. Dyspnea, stridor, tachypnea, coughing, respiratory signs for cats. Septic shock is caused by the presence of toxins and bacteria in the blood and other tissues. These patients have brick red mucous membranes, much darker than you would normally expect to see in a healthy animal. They are hyperdynamic. They have a rapid capillary refill time. It might be like less than a second, like the fastest capillary refill time you can imagine. The heart rate is racing, so they're tachycardic. Their pulses are bounding. Often they're hyperthermic. And interesting, some patients in septic shock are hypoglycemic, so their blood glucose level is decreased. And I think of this as the glucose is consumed by the sepsis. And so hypoglycemia is common with septic shock. We're going to talk about heat stroke later on, but the high temperatures cause organ damage, vasodilation, and maldistribution of blood flow. Envenomation would be like from a rattlesnake bite. And again, that can cause inappropriate vasodilation. We can get intravascular coagulation and distributive shock. Obstructive shock occurs when the venous return to the heart is impaired. So when a dog has GDV, gastric dilation and volvulus, the size of the stomach compresses the caudal vena cava and blood flow can't get back to the heart. And so we see clinical signs of shock because it's obstructed by the huge stomach. Likewise, if a dog has pericardial tamponade, the blood flow can't fill the heart again. It's the chambers are squished inside the pericardium, and so the venous return is obstructed by the pericardial effusion. And I just want to talk about pericardial effusion a little bit more. When a patient has pericardial effusion, we also see electrical alternans on our ECG. And so what this is the heights of the QRS complex alternate. We'll have a tall one, we'll have a short one, we'll have a tall one, we'll have a short one. And corresponding to this, the patient has pulsus paradoxus, which means that the pulses alternate, weak, strong, weak, strong. And that's because the heart is swinging back and forth in that pericardial sac. In order to treat pericardial effusion, we need to perform pericardiocentesis, which means we stick a needle into the pericardial sac and drain that extra fluid. Obstructive shock is best treated by addressing the underlying cause. So if it's GDV, we need to fix the stomach. If it's pericardial effusion, we need to drain the pericardial effusion. Cardiogenic shock occurs secondary to heart problems. So patients will have weak pulses, hypotension, and pale mucous membranes. Other signs could include cold extremities, pulmonary edema, or ascites, and then often we're going to hear a heart murmur as well. When a patient is in cardiogenic shock, fluids are contraindicated. They would make the workload harder on the heart. And so treatment really is based on improving heart function. We might use diuretics to resolve the pulmonary edema, and then we might use some sort of positive inotrope to get the heart working better. But no fluids for cardiogenic shock. We need to remember that. During shock, an inflammatory response develops even if no infection is present. And this inflammatory process can just be local and cause systemic inflammatory response syndrome, or SIRS. SIRS causes widespread vasodilation, which then leads to low blood pressure, an increased heart rate, increased respiratory rate, fever, and can also affect the white blood cell count. During SIRS, we can have inflammatory mediators released into the circulation, which recruits white blood cells and platelets to activate the clotting cascade. And now we can get little tiny clots inside all of the capillaries that plug up blood flow, and that worsens the inflammatory response. And then the platelets and clotting factors get consumed by all of these little clots. And so then there's none left for normal physiologic clotting, and spontaneous bleeding occurs. And this is a pattern of little thrombosis, like the clots are clotting in the vessels inappropriately and bleeding. And this is called disseminated intravascular coagulation, or DIC. And this is a pretty serious complication of shock with a pretty poor prognosis. Despite treatment, DIC is often fatal. Another challenging complication of shock and sepsis is multiple organ dysfunction syndrome, or MODS. And basically, as the SIRS response progresses, organ failure occurs. And so MODS means that where we started with just some systemic inflammation, now we have multiple organs that are failing. And it's most commonly the kidney, liver, lungs, brain, and heart that are damaged. So treatment is focused on maintaining blood flow. We want to give fluid therapy. We might use vasopressors. We might use antibiotics, transfusions. The prognosis for these SIRS, DIC, and MODS is poor. So we're always trying to address shock before our patient deteriorates further. I want to talk about the resuscitation phase of fluids. So this is for reversing that hypovolemic shock. And because patients are in a critical state, we're going to bolus these fluids over 15 to 20 minutes, which is different than our other phases of fluid therapy, which might be replenished over 24 hours. So traditionally, we start with a quarter of the shock dose over a 15-minute period and then reassess our patient's perfusion. So in the chart here, you can see that isotonic crystalloid has a shock dose of 80 to 90 mils per kg for the dog and horse. And so what we'll start with is somewhere around 20 to 30 mils per kg. Hypertonic crystalloid is going to be a much smaller volume. It's really potent at drawing fluid into the intravascular space. Remember, water follows salt. And so for the dog, the total shock dose is 3 to 6 mils per kg. And we're going to go ahead and start with that. So we don't cut the hypertonic crystalloid shock dose into quarters the same way that we do with the isotonic crystalloid. The third resuscitation fluid we have on here is the colloid. Remember, colloids are fluids that have really big molecules in them that attract the fluid and pull the fluid into the intravascular space. Colloids could be like blood and plasma, but they also could be synthetic, like hetastarch has these really big molecules in it, and it's a colloid. So the shock dose for a dog for colloids are 20 to 30 mils per kg, and we're going to start with about 5 mils per kg. So I think it's important to remember the shock doses for isotonic crystalloids, and then keep in mind that the volume for hypertonic crystalloid and colloids is much lower when our patients need them for shock. Okay, now we're going to get into some specific types of emergencies. So let's start with respiratory emergencies. When we talked about triage, these are the things that we want to address first. And that directly relates to my first question on here. How many minutes before there is irreversible damage from a lack of oxygen? Like, how many minutes until that patient dies if they are not breathing? Do you know? It's 3 minutes. Unless they are pre-oxygenated, then it's 5. So we really want to get oxygen into these patients as soon as possible. What are signs of respiratory emergency? So we're generally going to be looking at the rate and the effort of our patient's breathing. They certainly posture differently when they're struggling to breathe. Most animals will be sternal with their neck outstretched when they're in respiratory crisis. For most types of respiratory distress, we have two things that are really important. We want to minimize stress because the more stressed out they are, the worse they breathe. And then we also want to give them oxygen. So for almost any type of respiratory distress, we can calm them down and give them oxygen. My favorite sedative and one that's commonly recommended in the textbooks is butorphanol. And that's an opioid. It's one of those mixed receptor opioids, and it's an antitussive, so it's good if they're coughing. It has minimal effects on the cardiovascular system, and it's pretty safe for most patients, especially at a dose of 0.2 mg per kg, IV, IM, however we want to get it into the dog. If we think that there's some sort of pneumothorax or pleural effusion, then we want to treat that with thoracocentesis. Let's kind of go through some of the specific respiratory emergencies. Collapsing trachea. So remember, this is when the cartilage in the trachea is extra soft and flattens out on inspiration when there's negative pressure. And it's really common in our toy breeds like a Yorkie or a Pomeranian. They're predisposed to collapsing trachea. So if we see a patient that has collapsing trachea, we're going to give them sedation. We're going to give them oxygen. We might try medical management. There are surgical procedures as well to try and place a stent inside the trachea to hold it open. But we definitely want to calm them down and give them oxygen in the short term. Laryngeal paralysis is really common in our large breed old dogs. I think of like an old lab or an old golden retriever. We're going to hear the stridor because the larynx doesn't open up properly. Again, we want to give them oxygen. We want to give them sedatives. If it's really severe, there is a surgery to correct laryngeal paralysis, which is the laryngeal tieback on one side of the neck. We're going to pull the larynx open permanently. But the consequence is that those patients are then at risk of aspiration pneumonia because their larynx is permanently pulled open. So it's not without risk and just for severe patients. A pneumothorax most often occurs from trauma. So these patients have been hit by a car or had some pretty big trauma to the chest cavity. And so we want to give them oxygen and sedatives, but as quick as possible, we want to perform thoracocentesis. So this is putting a needle into the thoracic space and pulling off the free gas that surrounds the lungs. And so then the lungs can expand again. Remember, when a patient has a pneumothorax, we'll often see the heart elevated off the sternum, and that's an indication of a pneumothorax. And you can usually see the boundaries of the lungs surrounded by air if you look closely. Brachycephalic syndrome is so common with our French bulldogs increasing in popularity all the time. So this is a combination of stenotic nares, so the nose entrance is really small. Hypoplastic trachea, the trachea is smaller than we would expect for a dog of this size. Everted laryngeal saccules, so these like swellings in the back of the throat can be everted, and an elongated soft palate, and the soft palate is so big and fleshy in the back of their throat that it causes an airway obstruction. Those are all the components of brachycephalic syndrome. If we have a stressed out French bulldog, we want to sedate it. We want to give it oxygen. If it's really severe, we want to intubate. And again, there is a surgical correction for the soft palate, the nares, and the everted laryngeal saccules. There's really nothing we can do about this small trachea. Feline asthma is really common. These cats are often tachypnic, but they still have their mouth closed when they're breathing. So they are breathing faster than normal. They're posturing like they're having difficulty breathing in I sort of call it a bread box. So they're sternal with their little feet tucked and their neck extended. And we're going to treat them with oxygen. We're going to give them bronchodilators like albuterol in an emergency, and then we're going to maintain them on steroids. And I have my own little snoring dog sitting right next to me. So sorry if you can hear her. The last thing on here is pulmonary edema. And so pulmonary edema is fluid in the lung tissue from congestive heart failure most often. And so it's caused by left-sided congestive heart failure. So in addition to our oxygen and sedatives, we want to give some furosemide or Lasix, which is one of our loop diuretics, to pull the fluid out of the lungs. And then the patient will increase their urination of fluid. So we'll kind of dry them up a bit with their diuretics, and that'll help them breathe more. Feline urethral obstruction is also an emergency, and this is common in our male cats because their urethra gets so narrow as it leaves the body. And so it can be mucus or stones or grit or schmutz, and potentially even really severe spasms can cause a urethral obstruction. The problem is that the potassium can no longer leave the body in the urine. And so the potassium starts to build and build. And as the hyperkalemia gets worse, we see effects on the heart. And this is why a urethral obstruction is life-threatening. So it's from the hyperkalemia. As the potassium gets higher, we see changes on our ECG. So the QRS will widen and we'll drop the P wave. And the heart rate slows down, so we'll see bradycardia. So if we have bradycardia in a feline urethral obstruction, that's a pretty sick cat, and we need to try and reverse their obstruction as soon as possible. We can stabilize their heart by giving them calcium gluconate. We're going to put them on IV fluids. They're usually severely acidotic, so we want to use a buffered fluid to help with their abnormal pH. And then we want to de-obstruct them or unblock them so that the potassium can leave the body. Gastric dilation and volvulus is a common problem in deep-chested dogs. Like I think of the Great Dane being our textbook type of dog that gets GDV. But other large deep-chested dogs can get GDV as well. A lot of times the history is that this dog is restless, panting, pacing, retching without producing any vomit. And when they come into the hospital, we're going to want to stabilize them. Remember, they can have obstructive shock, so their venous return to the heart is blocked by this huge stomach. And so they're often, they might be in lateral recumbency and in shock. Usually we can see the distended abdomen and it palpates really firm, especially up high in the cranial abdomen, like right behind the ribs. So initial stabilization, we want to get a large bore catheter in the front legs. Remember, our fluid returning from the back legs is not great. We have obstruction and the fluid in the caudal vena cava isn't really getting to the heart. So if possible, we want to get our IV catheter in the front legs. Then we want to decompress that stomach. So we might use a orogastric intubation, passing a stomach tube. If that doesn't work, we might try chokerizing it, where we place a large bore IV catheter into it and try and release as much pressure as possible. We want to take our radiographs to confirm GDV and then get them to surgery as soon as possible. When these patients are in surgery, we often see ventricular premature contractions on their ECG. And if they're at a slow rate, it's not too concerning, but if they're coming in rapidly, especially at a rate of over 150 beats per minute, depending on your normal range, then we want to address them. And so we would treat those rapid VPCs with lidocaine. The stomach looks like a Smurf hat with a GDV. So I have a classic picture over here, but some of them aren't that clear. There's definitely cases that it's harder to appreciate. Eclampsia occurs in small breed dogs after giving birth to a large litter, and they give so much of their own calcium in the milk to help those growing puppies that their body becomes depleted in calcium. So this could also be called periparturient hypocalcemia. And dairy cows get this as well. So dairy cows get milk fever usually about 48 hours after postpartum. Dogs, it's usually about 1 to 3 weeks postpartum. And what we see is that this lactating dog has muscle tremors, fasciculations, and a stiff gait. We want to restore their calcium levels slowly. We're going to put them on calcium gluconate. Now, if you give calcium gluconate too fast, you can stop the heart, cause cardiac arrest. And so typically we put them on a nice syringe pump. We give it slowly and we watch their ECG at the same time. So we have continuous ECG monitoring on them. Next, we have our trauma to the nervous system. And so seizures or head trauma we're going to talk about. Let's talk about seizures. So there's many different causes of seizures. So it could be congenital, an inflammatory or infectious problem. It could be a toxin. It could be cancer. It could be epilepsy. And treatment in the hospital includes giving it some sort of benzodiazepine. If your clinic stocks diazepam, that's what we're going to give. If they have midazolam, we're going to give that. Ideally, giving it IV. We also could use the injectable phenobarbital, and as a last case resort, we could induce basically with propofol, and that will typically break a seizure as well. Some types of seizures are not emergencies. So if we have a known epileptic, those patients might be managed with anticonvulsants and we still expect them to have a seizure occasionally. It's usually when it's a new seizure, like it's never happened before, or if we're seeing a cluster of seizures where we have multiple seizures in one day, or where we have a pretty long seizure, so lasting for a prolonged period. Those are more of an emergency than a dog who's had epilepsy for 5 years. They don't have to come in for every seizure that they have. Next on the list is hypoglycemia. So this is low blood glucose, and I think of it most commonly in like a toy breed puppy. They might get rushed into the treatment area because they're unconscious and having seizures. And the first thing we want to check is their blood glucose. If they're hypoglycemic, we want to restore their blood sugar. The dextrose comes as 50% in a bottle, and we can't give that IV because it causes phlebitis. So it's really irritating to the veins. So it needs to be diluted. And we don't give it in the subcu fluids either. So I would typically drizzle a little bit of 50% dextrose on the mucous membranes while we're making our IV fluid dilation, usually 10% dextrose in fluids. And then as soon as we get the blood glucose up, we're going to try and get some food into that puppy because that'll also help maintain their blood glucose better than just straight dextrose. Head trauma, again, might occur from like being hit by a car or, kicked by a horse or some other severe trauma. We could see anisocoria with head trauma, which is where one pupil is larger than the other. So they're different sizes. We generally want to give mannitol. That's our osmotic diuretic to pull fluid off of the brain. We want to elevate the head approximately 30 degrees in order to decrease intracranial pressure. Now, this is really tricky to teach to clients. So usually I just ask them to get the patient in as fast as possible. And then in the hospital, if we know we have head trauma, we can put the dog or a cat on a board and then a towel to elevate their head about 30 degrees. Acute paresis or paralysis. So remember, paresis is weakness and paralysis is the lack of movement. And so these might happen with in herniated intervertebral disc. I think of the long and low patients being at risk for this. So the dachshunds, French bulldogs get it a lot as well. Corgis, beagles, bassets. I guess bassets more than beagles. And so treatment might be conservative. We might try some sort of anti-inflammatory and strict rest. But the more severe cases typically need surgery in order to walk again. And so the surgical intervention is either a laminectomy or a hemilaminectomy performed by either a neurologist or a boarded surgeon. But that procedure is really delicate, so it's not typically done in general practice. Now, some dogs with really severe herniated discs come in with a Schiff-Sherrington posture. And this occurs when the lesion is somewhere between T3 and L3. So that means right in the middle of the spine between the third thoracic vertebrae and the third lumbar vertebrae. And they have rigid extension in their front legs and flaccid, paralyzed back legs when they're in that Schiff-Sherrington position. And I'm just mentioning it so if you see a picture of the Schiff-Sherrington posture, you can recognize it on your VTNE. And that usually is a lesion in the middle of their spine. I used to think it was up higher, but no, it's T3 to L3 for Schiff-Sherrington. Heat stroke can occur in the summer when we have a hot day and it's humid and we take our dog out for a walk, and maybe they're a thick-coated dog that doesn't pant well or doesn't cool off very well, and their body temperature rises and rises. So anything over 107 can lead to organ failure and death. So if our patient's over 107 degrees, their prognosis is guarded. We're going to try and cool them off, and we want to cool them internally. If we just plunged them into ice, the skin would all the vessels in the skin would vasoconstrict, and that would trap the heat in the body. So we don't want ice water on their periphery, but a cool water bath is fine. We want to get them on nice, cool IV fluids, so we're treating them inside with cool fluids. We might give them a cold water enema. We might put a fan on them. And sometimes we'll try, putting alcohol on their foot pads or ice packs in their axilla or groin. I mean, these things are, variable based on where you practice. Now, as we're cooling them, we want to continue to watch their body temperature. When they reach 103 degrees, we need to stop our active cooling, because even after we stop active cooling, their body temperature will continue to drop a couple more degrees. And if we waited to stop our active cooling until they were at 100, they would drop down to 96 or 97 degrees. And now we have a hypothermic patient that we need to warm up. Okay. So the standard is to cool until we get to 103 and then stop the active cooling. Take the fan off, get the fluids out of the ice water. You can just sort of let them naturally continue to drop to normal temperatures. It is so important that you can recognize dehydration. I think this comes up sort of in different domains. So when a patient is dehydrated, their PCV tends to be elevated. That's their packed cell volume. There's more cells and less fluid, so the PCV appears higher. The albumin is higher from dehydration, and sometimes the BUN and creatinine can increase from dehydration as well. If it's truly dehydration, we would see an elevated BUN and creatinine in conjunction with really concentrated urine, so a very high specific gravity. Our patient is often has lost weight when they're dehydrated, so their weight is down. We could see a delay in skin turgor when they're dehydrated. Their mucous membranes might palpate tacky or kind of sticky instead of being kind of moist and slimy. Their eyes would appear matte instead of glossy, and often they would appear kind of sunken, like they're not as bulgy or not in their normal position in the socket. So be sure you can recognize all those signs and understand what dehydration does to blood work as well as clinical physical exam. Next, we're going to cover a couple emergency nursing procedures. The first one is thoracocentesis, and this is the procedure to remove either fluid or air from the pleural space. Remember, the pleura lines the thorax, so we're talking about getting a sample or relieving the pressure in the thoracic cavity. And thoracocentesis can be either diagnostic, and so we want to figure out what type of fluid is in there. We might collect a sample just to figure out what's going on. Or it could be therapeutic. So if we have a patient who's having a hard time breathing, removing as much fluid as possible will help them breathe better. Our patient needs to be in sternal recumbency. We use a 18 to 22 gauge needle or catheter, depending on the size of our patient. Sometimes I like a butterfly, especially for cats. We're going to connect that to a 3-way stopcock on a large syringe. And when we insert the needle, we want to stay on the cranial aspect of the ribs. And that's because all of the arteries are on the caudal aspect. And we don't want to stick a needle right into the arteries behind the ribs. So you go right in front of a rib. If we are trying to remove air, we will insert the needle dorsally. And that's because air rises, it's less dense than fluid. And so our thoracocentesis for air will be between the 7th and 9th ribs dorsally. If we're trying to remove fluid, we're going to stick our needle ventral, and again between the 7th and 9th ribs, but pretty ventral, usually right around the costochondral junction is where we're going to insert our needle. And I like to use ultrasound to guide my needle for this if possible. The next procedure is abdominocentesis, and so this is used to remove fluid from the abdomen. Remember, fluid in the abdomen might be called ascites, peritoneal effusion. It could be blood, so some patients have a hemoabdomen, and that's what the fluid is. But a lot of times we don't know what the fluid is until we get a sample. So again, abdominocentesis can be diagnostic or therapeutic. Diagnostic is to get a sample and try and figure out what's going on. Therapeutic is to alleviate some of the pressure and provide comfort to our patients. For abdominocentesis, our patient is usually in lateral recumbency. Again, we're going to use an 18 or 22 gauge needle connected to a 3-way stopcock and a syringe. And it's best to insert the needle on the right side to avoid the spleen. Remember, the head of the spleen is attached in the left side of the abdomen. But we want to go where gravity is, the gravity dependent area, which is like on the bottom. So fluid will sit on the bottom of the abdomen because of gravity. And so that's where we're going to stick our needle in. And again, it's nice to use ultrasound to make sure we have a good spot and guide our needle. Blood pressure is important for many of our critical patients, and just a reminder, we can measure blood pressure in different ways. So most of the ways we're using with anesthesia or just in clinic is indirect. So this is like the Doppler sphygmomanometer or the oscillometric blood pressure, which is in our multi-parameter anesthetic monitors like a Midmark or Cardell. Those use an indirect method of blood pressure. We're not in the heart, in the vessel. So if we wanted a direct blood pressure, we need to place a central venous line, which is inserted into the jugular vein and fed into the heart. And then we measure the level of water, and between 0 and 10 centimeters of water is normal. This is really only done in ICUs, in referral hospitals. I think it's rare you're going to see this in a general practice setting. Okay, the last section of this lecture is on toxicology. And so just remember, we're supposed to treat the patient, not the poison. Every animal has its own response to different, toxins. First thing we always want to do is try and decontaminate. So we want to get the toxin out of their body if possible. If it's in their eyes, we're generally going to flush. We can either use tepid water, which is not too hot, not too cold, or we can use some sort of saline eye wash flush. We want to do that as soon as possible to try and get it out of the eyes. If it's something that's on their skin or coat, we're going to give them a bath in a dishwashing detergent. And the dishwashing detergent usually cuts oily secretions or oily substances really well. And so it's effective at getting things off of the dog quite readily. Now, if an animal has an oral exposure to something toxic, it really depends on what the substance is with how we're going to treat it. And it's always ideal to contact poison control and get specifics for the patient and the amount and the specific toxin that's been ingested. But here's just kind of an overview. If we have something that's really corrosive, we might want to dilute that. So we might want to give them milk or water. If an animal's eaten something toxic, like say they ate a bunch of chocolate, most things are going to be in the stomach for the first 4 hours, and inducing vomiting is going to be effective. If you wait too long, a lot of the gastric contents have moved on into the intestines. Again, it depends on the specific food that we're talking about, but over time, inducing vomiting will be less and less effective to decontaminate the patient. And just a reminder, we prefer apomorphine for dogs and alpha 2 agonists for cats to induce vomiting. We might also give active charcoal, and this will bind the toxins and prevent entry into the bloodstream, especially for things that have moved on into the intestines. We don't want them to be absorbed and reach the bloodstream. So charcoal will kind of bind them in the guts, and then they poop it out, and it doesn't cause problems. So we'll just talk about a few specific toxins. So moldy foods can contain a tremorogenic mycotoxin. So this is like a moldy toxin. I think of moldy walnuts causing this, that can cause tremors. Chocolate contains the ingredients theobromine and caffeine. Both of these are methylxanthine stimulants, and they cause the patients to have GI upset and a rapid heart rate, seizures, tremors. So it's dose dependent, and the stronger the chocolate, the more theobromine and caffeine it contains. Onion and garlic can damage red blood cells, cause oxidative damage. Grapes and raisins can cause kidney failure, acute kidney failure. Xylitol, the sweetener that's in chewing gum, can cause severe hypoglycemic episodes and liver failure. Zinc also causes oxidative damage to red blood cells. Lead can affect the gut, the kidneys, and red blood cells. If an animal eats lead, we give them a chelator like EDTA. So EDTA will bind up the lead, and then it can be excreted. There's quite a few plants that are cardiotoxic. So here's just a couple of them, but oleander, lily of the valley, and foxglove are cardiotoxic. So they're going to cause problems with the heart rhythm, most likely. Lilies can cause acute kidney failure in cats, so that's pretty toxic to kitties. Metaldehyde is the active ingredient in a lot of types of snail bait, snail or slug bait, and it makes our patients shake and bake. So they get tremors, and all of that muscle activity leads to increased body temperatures. And then we essentially have a patient with heat stroke, like we talked about earlier, so we can have organ failure from the high temperatures. There are different types of rat bait out there, but the anticoagulant rat bait is generally called brodifacoum or warfarin, and this inhibits vitamin K in the clotting cascade. And so the rat, if they eat the rat bait, bleeds to death. They just bleed through every pore. But if our pets ingest it, they also bleed and can bleed to death. But fortunately, we can supplement and give them vitamin K, which is the antidote. So it comes as an injectable and also as a pill. So we would send them home on vitamin K pills, for a few weeks until the rat bait is out of their system. There's a newer type of rat bait that's neurotoxic, and that's called bromethylin. And unfortunately, vitamin K is not the antidote. In fact, there's no antidote for the bromethylin rat bait. So it's a little bit trickier to treat. We just sort of treat the symptoms, decontaminate an active charcoal and treat the symptoms, but we don't have a specific antidote for bromethylin. Gopher bait can contain zinc phosphide, which is when it's metabolized, it releases a poisonous gas. So if we have a patient who's ingested gopher bait, we want to induce vomiting in a really well ventilated area. So I had one of these cases when I was in practice, and we took it outside and induced vomiting outside on, where we had a good breeze, because the zinc phosphide gas is even toxic to us, the people working with the dog. Okay, just two more toxins here. Antifreeze is used in cars to prevent fluids from freezing, and it contains ethylene glycol. That's the active ingredient. It causes acute kidney failure and calcium oxalate monohydrate crystals in the urine. We commonly see calcium oxalate dihydrate crystals. I think of like a Bichon that might have slightly acidic urine. These are specific to antifreeze toxicity. So the calcium oxalate monohydrates primarily just occur from antifreeze toxicity. If we have one of these cases, we're going to treat it with either fomepizole or ethanol. Some clinics just stock a bottle of high-quality vodka to use for these patients. And then last we have acetaminophen, commonly known as Tylenol. And this is extremely toxic to cats. You know, we can use Tylenol in dogs. It has a narrow range of safety, but it is safe in the proper range. But to cats, it's extremely toxic, and it causes hepatic necrosis, so liver damage, and methemoglobinemia, so it really damages the red blood cells. That methemoglobinemia makes them look brown. So it's pretty typical if you have a brown patient or brown urine that we're talking about a Tylenol toxicity. And the antidote for acetaminophen toxicity is acetylcysteine. Whew, that was a long one. Hey, I just want to wish you good luck on your VTNE. It's a tough exam, but you can do it. I have faith in you. Keep studying, keep practicing, and you'll get there. Good luck.